Thank you so much. It is a pleasure to be here with each of you, and I look forward to speaking more with you over the weekend. And as we've seen, challenges abound for all of us. And I think once you see some of the challenges I share with you about from North America, you'll see that there are some similar challenges that we face as well. And as a group here together, we can come together to bring information to each other that will help us as we work in our own individual countries. So thank you again for the opportunity. Some of the challenges that we've already heard and that are prominent in the United States is access to therapy. Okay, keep talking. Will do. I can do that. No comment from the crowd. But access. And many of the patients in the United States and Canada are covered by insurance policies, but many of those insurance policies do not cover the drugs in a way that is affordable for that patient. So just as in your country's access issues abound, they abound also in the United States. We are working on a number of different ways in order to provide access and to ease the burden on the patient population. One of the things that we find is that insurance policies in the United States do not look at oral cancer therapies as they do IV counterparts. Those therapies are looked at, IV cancer therapies are looked at as a major medical expense and is generally covered for people in the United States with insurance. For those people that do not have insurance, of course, it is out of pocket. For those people that have insurance and are on an oral cancer therapy, that is under a different part of their policy as their prescription drug plan. And so many patients are paying anywhere from $3,000, $5,000 copays per month, and some can pay even more. So it's a big issue that keeps many from accessing the drugs as easily as they could. Varying coverage and co-insurance amounts. Many of our insurance policies, while they do cover the drugs that are available for CML, they're covered at a rate where the patient, again, has to pay a huge portion of that. So it leaves excessive out-of-pocket expenses. And many are underinsured or uninsured. The same is happening in the provinces in Canada. I know the CML Society of Canada has been working with provinces on oral parity, making sure that oral cancer therapies are compensated by insurance programs and state plans as equitably as their IV counterparts. Another challenge, or group of challenges that we face, regards adherence, testing and monitoring, disease education, and research input. A lot of times there's a misunderstanding or an inadequate understanding of the importance of adherence. I know many of you follow social media platforms where discussions are going on all the time with groups of patients, where we see those that are beginning trials of one. In other words, I'm going to stop taking my drug because first off, I can't afford it, and I'm going to see how things turn out. But I'm not having good monitoring, so I don't really know where my counts are or my numbers are for my CML. As a result, that puts many at risk for problems with their disease. Inadequate understanding. The newly diagnosed, the role of adherence needs to be understood as it applies to future ability to stop therapy. Intolerance and side effect management. We've heard this come up over and over again today. How do we work with our regions to address those issues? Because now, gratefully, we're living longer lives and able to go on and do the things that we've always wanted to do. And also, those access and drug coverage issues do have an impact on adherence in North America. There's the insufficient knowledge of monitoring and testing. What is a PCR? How does it impact my life? And there are a number of things that we're doing with other North American organizations as well as your organizations to help spread the word about PCR testing, the importance of that testing, and developing a knowledge there. Quality of life and strategies for living with a chronic illness. As Dr. Drucker said in his introduction, now that we have the opportunity to live life, we have these real issues that we must face on a day-to-day basis, those quality of life issues. And there's also, as far as research input, as we discussed this morning in Yan's session, few opportunities for patient engagement at a research level in North America. And so we hope to do something to work to improve that. Some of the priorities, and I'm talking specifically about Canada and the United States. And we have many drug parity issues that are being taken to the states and also taken to the provinces all across Canada. Drug parity calls for insurance companies to cover the oral cancer therapies no less favorably or in line with those insurance coverages for IV cancer treatments. But this mandate is down on a state level in the U.S. So there's 50 states that are in the process of being educated about drug parity. To date, approximately 30 states have initiated drug parity legislation, and our most recent, just day before yesterday, the state of Arizona became the latest state to ratify drug parity legislation. And so those patients that are living with CML in the state of Arizona will now be able to get their CML drugs at a lesser cost. We're also, in the states, some particular acts that are in process. The Access to Treatment Act and the Part D Beneficiary Appeals Fairness Act. Both of those acts deal with, first off, requiring insurance plans to limit the cost-sharing requirement or the tiering of those drugs so that those drugs are placed in an area, a financial place where they can't possibly be afforded. The Part D beneficiary parts, and I know these are, this is all Greek. Who are Greek speakers? You'll translate for me. The Part D part has to do with our Medicare and Medicaid government-issued insurance coverages. And this ensures that senior citizens can access these same medications without these specialty tiers that prevent them from accessing the drugs. So the priorities for adherence, testing, monitoring, and disease education and research input, we have worked to do a lot with adherence. We participated in the adherence survey and are so thankful to see the results that came from that and have been able to share that with people in our country. We've also, I know the National CML Society has published an adherence guide that was distributed across the country. The LLS has done many programs on adherence and had speakers in to discuss the importance of that. And other organizations do that as well, outside the parameters of just CML. We are providing ongoing opportunities to learn more about living with CML. How do we mitigate side effects? How do we deal with quality of life issues? And then also opportunities to learn more about treatment cessation. As I mentioned earlier, on many of the social network platforms that we and many of you visit, we see trials of one going on, where someone decides that I've seen information coming from other countries where studies have been done where people can come off of therapy. Currently, right now in the United States, we're very limited in the amount of locations where we can go and actually engage in that discussion freely about stopping therapy. So many are taking that onto their own plate, so to speak, and they are beginning to experiment. And what our goal is, collectively as organizations in North America, is to explain the importance of adherence as it relates to cessation training so that those that are newly diagnosed and even those that have been diagnosed for a long time will understand that we must meet certain benchmarks before we try stopping therapy. We want safety and security of your response and of your life to be paramount. So these are things that we're working on as priorities. And of course, we're working to develop inroads into the research design process. So as far as initiatives go, as they relate to these things that I have shared with you, drug parity and access acts, we're working to provide access to education on parity issues both in the states and across Canada, and to provide and promote action opportunities. This coming Monday, the LLS has an action day in Washington, D.C., where we will be going to Congress and sharing the importance of these initiatives for fair access to drug therapies at an affordable cost. And so we provide all these activities throughout the year for our patient populations to learn more and to learn how to approach their government officials and to make a difference in their region. Initiatives on adherence, testing and monitoring, and disease education. We're providing access to opportunities for teleconferences and webinars. I know each of our organizations participate in those and provide those. An adherence guide that I mentioned earlier that National CML Society had produced with Patient Resource Publishing. The What is My PCR campaign, initiated and shared by the Max Foundation, and all of us have had a great success in being able to share that with our regions. We're connecting to leading CML physicians and researchers. A number of our organizations in the states are working together for a cancer experience registry for people living with CML, and that has been a very successful venture, and we're continuing to see it succeed. And we're looking at other opportunities to collaborate together to make sure that the population of CML patients in the States and North America and Canada have the information they need to make informed decisions on their care. So with that, I'd like to thank the CML Society of Canada, the Canadian CML Network, the Cancer Support Community, the Leukemia and Lymphoma Society, and the Max Foundation, and also thank CML Advocates Network for the opportunity to present. And would our North American delegates stand, please? I know you're here somewhere. Pat, you stand too, because you're going to have to stand in. Where's Aaron? You better stand up. But thank you so much. Come on, Gail. That was a really weak attempt at.
She's waiting for the luggage.
Is that what it is? But these individuals work tirelessly throughout the year, and we have a great collaboration across North America to work together to ensure that the CML community gets what they need and has the information they need to live their life well. So.
Yes, please.
Greg, I got a question. Just now you mentioned about there are potential patients who may not get because of high cost and they are not enrolled in the insurance. So, and in this case, they can't get access to the oral medication, for instance, the CML case. So how do this patient get by, in the American situation?
Thank you very much.
Has they got any channels where this patient could try and get access?
Yes, very good question. There are those that end up outside the parameters of affordability of the drug through their insurance.
1 minute, I get you the water.
No comment to you that were sitting at my table last night, or from you. What we do is we try to qualify them for patient assistance programs, many provided through the drug companies and other organizations in the States and North America that do provide assistance with co-pays and access to drug therapies. The problem happens when the patient falls outside the parameters of those assistance programs. And therefore, at that time, we literally have to go grassroots to try to raise funding for those patients. We have great relationships with all of the companies that produce these drugs, and they've been very helpful to us in getting drug to patients. But many times, the simple access programs, they're not simple, but if you're looking at just the access programs, income requirements are surpassed, and therefore there is no option readily available. So we've had to think outside the box a lot of times on trying to get drugs provided for the patient. I hope that answers that.
If I may ask you, and actually it's also asking other regions. Last ASH, when we met the patient advocates, we heard from the LLS and also from you about your efforts trying to understand the differences in the survival rate of patients, CML patients who are entering clinical trials. When most of us, we are aware that we get the data that, let's say, from the IRIS, almost 90% of the patient survive the 8 years margin. And then in tests that you did in your country, the survival rate of CML patients who are not in a clinical trial, what we call in a normal daily life, is closer to 50%. So there is after a similar period. So you found that there is a big gap between the survival time of patients who are in the trial or patients who are outside of a trial. So my question is doublefold. One to you is how are you handling it? And I know that the LLS is working very hard to try to understand this gap. And also to hear from other regions, do you see this gap or differences between survival dates in your region as well?
I know one of the things that we are doing, and Gail, all of you joined in, the Leukemia and Lymphoma Society, the Cancer Support Community, the Max Foundation, and the National CML Society are now collaborating on a cancer experience registry for CML. And as we see these experiences, we begin to see trends that can give us some indication of what could be happening to contribute to the change in those numbers. It is disturbing to see that the numbers have gone up in diagnoses for CML in the United States, but it's even more disturbing to see when the death rate has grown. And from just a rough estimate I've seen, the latest was 810 deaths per year in the United States to CML, and that number has usually hovered around 400 to 500 people. So there's been an increase there. So we're trying to determine, is it an adherence issue? Is it an affordability issue? Just exactly what it is. And so we're trying to make sure also that through social media conduits and other communications, that real, relevant information that is vetted by professionals that know this disease is out there and readily available for the patients. Gail, would you have anything that you'd want to add?
Gosh, I don't really think I can add too much more to that. I think I just wanted to add to what you were saying about access issues and availability of medication. I think there's, it's somewhat surprising to some folks here that it's really, access is still a huge challenge in the U.S. And, on a daily basis, we have people that, and I liked your use of, creative management, that fall outside the box and either don't qualify for co-payment programs or don't qualify to receive the drug through the pharmaceutical companies, or live in distant areas and don't have access to good CML experts. Because I talk to people on a national level, I know that to be very true. I think when somebody is really persistent, they do ultimately get their medication, or your organization, ours, helps them one way or another to get their medication. But I think we have to remember that there are still a lot of rural people, poorly educated people that are probably accounting for some of those numbers.
And we've also heard people talk about in their regions educating physicians and treatment professionals. We find that the further we are removed from a medical institution that is a teaching hospital, the results in response go down, because perhaps it's that old mentality that, oh, it's just a pill, take this pill and you're A-okay, when their treating team might not be recognizing some of the subtleties that are in place that are going to have an adverse effect down the line. So.
Cheryl Ann from Canada. I can just say here, for as far as the long life of Canadian CML patients, I think that's directly related to the fact that while we do have challenges with access versus the IV drugs to oral cancer drugs, we do have a lot better coverage all in all than our friends and our neighbors south of the border. So we're not seeing that we're not seeing that decline in the lives of CML patients. They're as if they're in a clinical trial because the coverage is good. But I think what we're going to be finding out more and more is we've started some CML registries in Canada. Quebec has really taken off with it. The rest of Canada has not yet, but they're developing those in partnership with some of the pharmaceutical companies. So I think we'll be able to track that data a lot better. But through Canadian Cancer Society, the statistics look very good for CML.
And Cheryl-Ann, help me here explain to the group, in Canada, the provinces, I know that you and others have been working with each province.
So what we did this past year was we went to each province is like its own little country. We have the federal government approves our drugs, but then each province has to cover decide if they want to reimburse it and to what level they want to reimburse it. Several provinces have picked it up, and so a patient goes and gets diagnosed with CML, they go into their hospital, they get their drugs given to them right and in the hospital without any exchange of money. But many provinces have not done that, and in some provinces it's prorated the coverage to your salary. For example, we all know Stuart Sklar, our lawyer and director. He lives in Ontario, and he pays $1,500 a month out of pocket, which is never reimbursed for his TKI. So that's how that healthcare system works in Ontario. The Ontarians are really having a rough go with it. So what we're doing is the Kidney Cancer of Canada got us all together under a cancer coalition, and we're taking it straight on to all of the provinces. We've actually visited every health minister and drug executive right across Canada, and we've been hitting them with petitions. We've got a lot of airplay. We've been really coming together as a group and working really hard with it. So it's on the table. There's discussions going on, but Canadian cancer patients who are not covered by this parity are severely discriminated in, because what happens is it's their work insurance that covers the drug when the government doesn't cover it. So the employers just try to get you off their out the door, so they don't want to have to cover your drug.
And some of the similar type things happen in the States with insured patients as well. Thank you to each of you from our region for sharing today, and I appreciate the opportunity to represent us today. Thank you.